welcome to another edition of Your Bridge to Addiction Resources, a program that is sponsored by the Council on Chemical Abuse and the People Chronicles. My name is Yvonne Stroman. I'm the Community Program Specialist, and today we're going to talk about how individuals can access treatment. The Council on Chemical Abuse provides public funding for those who do not have their own insurance. And when they need help to gain access to treatment, we provide those public dollars so that people can have the greatest chance of getting well. So I thought it would be a great idea to bring in one of my colleagues that works in the office, and I'll allow her to introduce herself and kind of give us a little bit about what she does at the Council on Chemical Abuse so that we can ensure those that want to get access to treatment, those that need access to treatment but can't afford it through their own pocket, how we do that through public dollars. So with me today,
my name is Bernice Hines Corbit. I'm the Case Management Supervisor at Council on Chemical Abuse. That's a really long word for person in charge of funding. So I do a lot of troubleshooting. This client has this needs, where can he go? She's pregnant, where can she go? So for the majority of our people do not have insurance, as Yvonne said. However, we have a lot of people that are underinsured, although we thought the insurance policies could not do that anymore, but there are a significant number of people who have insurance plans without drug and alcohol services. So we also will review to see if we can fund those guys as well.
So Bernice, in terms of accessing those dollars, an individual, maybe through a family member, or maybe even through going to the emergency room because of an overdose. You know, we have this huge epidemic with the opioid crisis and heroin overdoses, fentanyl use, those kind of things. So their first meeting can be with a medical professional who then says, you know, you may have a problem, or the person even gets honest and says, I think I might have a problem. And so, but they can't afford it on their own. What are the steps that that individual needs to go through to be able to get that funding that you speak of? Okay.
There are many different access points to access COCA funding. A lot of people don't know that the bulk of our people go into the TASC office, 19 North 6th Street, and that's first come, first serve. They walk in there. I get many calls, however, from hospitals, most importantly Reading Hospital, outside of Berks County, maybe Horsham Clinic, and different psychiatric hospitals. With Reading Hospital being as large as it is, we've been really lucky that the social workers, they know to contact COCA for funding. For clients who don't have anything, they know they can reach me for just resources. Hey, we have a client who has insurance, but I have these kind of questions. This case seems a little odd. Can you steer me in the right direction? So if people are coming in through the ER, as we work on our warm handoff program, most of those people are able to go from the ER, if they're willing, to a detox program. If that detox is full, we have a way to try to expand the circle for other detox referrals. If they need they've already detox, they need residential treatment, then the social workers, they'll send me information to review to see if we can fund that person. But like Yvonne said, family members, lots of girlfriends and mothers, bringing people in by the ears, sometimes employers, EAP professionals.
What's EAP?
Employment assistance programs.
Okay.
Like an employer may say, you know, pull an employee aside and say, your work is subpar. What's going on? And the employee may have already disclosed that they had a drug and alcohol issue.
Okay.
And the employer can say, okay, I'm referring you to the EAP, and you have to follow through whatever the recommendation is.
Okay.
And we can help that person sort through insurances, trying to find a provider that fits their needs. Word of mouth is huge. That's huge. A lot of people come in because a family member, a neighbor's brother heard something. So word of mouth.
So you talk about the hospital or the detox might get in touch with you, or the residential treatment might get in touch with you, and then you, in your capacity, which you've been doing for a long time, right, for a number of years, you kind of take a look at the level of care that they need, Or is that already given? Is that a recommendation? Do they go in and there's an assessment that's already, the level of care is given, or do you determine that level of care? Or is it a little bit of both?
A little bit of both.
Okay.
Now, if an agency like TASC is going to call, they've already done the assessment. If one of our local outpatient providers call, they've already done the assessment. And the hospitals are gearing up and educating their social workers on insurance processes, including county funding. They're getting them trained to use treatment language.
Okay.
So they're close. They're getting close.
Good.
They'll know that the person needs detox and or rehab. So they'll send me the information, I'll review it, and we'll start conversing from there to find out what's the best for that person. Sometimes people might come in and really having acute withdrawal symptoms. In the hospital, the medical doctors might start treating that person medically, which could create an issue on what type of level of care they can go to. So I have to screen that out, like what medications are they on, because certain things are not accepted at certain levels of care.
Right.
But for the professionals, they're doing the best they can to keep up with current jargon and treatment tools. Maybe a family member or someone on the street, they just know this person needs help, and they're very thankful. Just help them.
Right.
So.
And so you and I are talking about we're using a lot of jargon, like levels of care. So the levels of care really, there are steps. There's detox, there's inpatient rehabilitation, there's halfway house, there's sober living. What is the difference between detox, say, and inpatient?
Okay. For when we say detoxification, the person literally needs to have their systems cleaned out, whatever substances they're using, and in a safe environment where there's a doctor
that can
and
monitor.
And medical personnel to monitor any kind of acute symptoms. And treat whatever other symptoms come up as the drugs leave their system.
Okay.
And once that's done, then we know exactly what we're doing with the person. I think it's preferable for a person to go from detox to residential treatment and not right back to the same situation. So we try to speak with that person in need and try to get them to accept the more extensive level of care. But we also have treatment on 1 time a week. We have treatment 2 times a week. We have treatment 3 times a week. So we would try to avoid that and do that after a residential stay to try to get the person out of that environment, get them detox where they can think clearer and make some clearer decisions and not rush them out the door. But there's a situation you have to deal with whatever you're presented.
All right. And that could last for, what is the timeline that could last for? Detox could last for how long? Inpatient could last for how long? Outpatient?
The time that a person stays in detox is usually determined by what they're using and what medications are needed to treat them up for detox.
Okay.
Some programs that have, some substances require at least 5 days before it's out of their system and vitals are stable before we can move them on. And a residential level care, we generally start at 14 and review from there. We average about 21.
Okay.
Now, when there's availability and also funding to match, we can sometimes send a person to a longer term level of care where they're going to start at 30 days and maybe be there for 60 or 90 days. There are also some situations where even after the detox and after the residential piece, that the person's willing, there's a bed available, we can, in a sense, step them down.
Okay.
From the outside, it doesn't seem like a stepping down because they're still in a residential program, but they might go to like a halfway house where they can do things like look for work, complete a GED program, while leaving the program during the day to work or get things done, but coming back to that safer environment to process each night before returning them to an environment where they're living independently.
Right. And I think it's important, and I've heard some folks saying, well, I'm trying to get off drugs. All I need is 3 or 4 or 5 days. Isn't that enough? And what's the response to that?
Other than a chuckle, we'd ask the person to, we ask the person to just try to be open, try to let go, and explain that their best decisions have brought them to us. Let us help them make some better decisions. But you have that.
Yeah.
And we try to confront them with their history, like their own history. Well, the other 2 times you tried that didn't work.
Yeah.
And luckily, being a centralized intake, centralized funding unit, we have a history of the person
Okay.
that we can remind them of.
Yes.
Saying, well, and say statistically, or my training says that doesn't work, and here's why. And see if we can come back and forth and see if we
Right.
can get them to stay for a little bit. And if they agree to stay for a little bit, maybe we can get them to stay a little bit longer.
Right.
And try that back and forth.
Right,
them.
wonderful, that's great. And so you've been doing this for a number of years. Do you think that there is more need out there for treatment? Because, you know, we had heard from our physician general not too long ago, even yesterday, that talked about there's a point in which this is all started in terms of, she talked about the opioid crisis, but I'm just talking about in terms of drug use or alcohol use in general, and the need for treatment. Has there been, have you seen that there's been an increase, or that level's really been there throughout, it's just not been as public? I'm just wondering what your perception is on that.
I believe that the need's always been there. The current trend with the opioid use, the symptoms and the consequences are fatal. They can be fatal. So there's way more damage being done. But you know, I've been doing this a while. When I came in, it was the crack cocaine and different things like that. I think the issue was access to treatment and education about treatment, because we're not reaching everyone. I think there's still people right now who are out there who need help, who don't know that we're here. Word of mouth is good, but we need more. We see a lot of the same people over and over again, but I believe there's still other people out there that we have not.
Some new people
we have not reached.
Okay.
I don't know, did I answer?
Yeah, good. So you know, having been in the trenches for so long, how has this impacted you personally and professionally as you work with people? And you had mentioned there are some people whose name resonates for you that have been through the system for years. How has this impacted you personally or professionally as you continue to do this work and try to help to save lives?
Well, for me and for people in the field, I don't think anyone should enter this field if they're not able to mentally leave the job at the door and pick it up when they come back. My goal is always try to help as many people as possible, or more importantly, if someone has a need, try to meet them with a resource. I know from the beginning of the day that I'm not going to reach everybody, or that we're not going to agree on what the solution should be. So professionally, I like to do a good job and get my job done. Personally, it gives me pleasure. It gives me pleasure.
That's great. Great. Is there anything that we, as we kind of wrap up here, that we haven't talked about that you really want to make sure that folks that are having the opportunity to view this may be left with in terms of how do we help those who really need the help? Is anything that we left on the table that you want to kind of just...
Well, I think as treatment providers, what we need to better explain is that we'll try to help everybody, and we'll try to remove as many barriers as possible. Maybe a woman with children. There's an outpatient program that helps with childcare, so they enter in treatment. We also have a residential program that if a woman has young children, she can take the children with her, because that's sometimes a barrier for women in getting into treatment. It's usually the kids. Yeah,
and I think that's important for individuals to know that there are systems in place that really help address what some of those barriers are. We've known for a number of years that oftentimes that women will kind of put off going to treatment because they feel as though they have to take care of the home, I have to take care of my children, I have to take care of so many other things that they often put themselves low at the totem pole to say, you know, I'll work with my demons, I'll wrestle with this on my own. But to know that there are services that actually work with families, and that we really try to address some of those barriers to help people be able to access treatment and to get the help that they need, because it really is a family disease. And it not only impacts the mom, but also that impacts ultimately the children as well.
Right. And as far as treatment access for clients who aren't going away to treatment, our outpatient providers, they have classes in groups during the day and also in the evening. So if someone's work conflicts with group time, we'll try to find a provider that can work with their group time or class schedules or whatever. So the treatment field's trying to be as accommodating as it can.
Wonderful. Well, thank you for stopping over and kind of having a chit chat with us about treatment and access to treatment. And if you would like more information about the Council on Chemical Abuse and the multitude of services that we provide, we invite you to visit our website at www.cocaberks.org. That's COCABERKS.org, or give us a call at 610-376-8669. This is your Bridge to Addiction Resources. My name is Yvonne Stroman. Thank you for joining us. Have a great day.
Check back every week for a new story with your Bridge to Addiction Resources. You can call 610-376-8669 or visit online at cocaberks.org. COCABERKS.org. Be sure to like and follow the Council on Chemical Abuse on Facebook and Twitter.